I'm sure at school you guys have been taught ADPIE'd. To ADPIE'd is so important. Every time we're in clinic, we are literally doing each and every one of these things. We're doing A for assessment. We're doing an assessment. So think about your health history, medical history. Think about extraoral, intraoral, hard tissue, radiograph. That is all helping you with assessment. It's all helping you find data. It's all helping you collect all the information so that once you have all the information, you can then diagnose. And we can do a dental hygiene diagnosis. And we'll look at this in more detail, but just as an FYI, we cannot diagnose caries. We can say we suspect that we have, we suspect that our client has caries on X and X tooth. We can't diagnose periodontal disease, so we can't say this client has periodontitis. We could do a dental hygiene diagnosis, but we can't flat out come and say you have periodontitis. That has to come from the dentist. Once we have a diagnosis that we would work together with the dentist with, then we come with a treatment plan or a care plan, and we plan everything for the client. So all the information we get from the assessment, anything that is a red flag for us, we will plan and we will help improve our client's oral hygiene in this treatment plan. We'll come up with a plan that is best for our client, and it is client specific. The care plan or the treatment plan will not be the same for every single client because every single client is unique. Their data that you collect in the assessment will be very different, or could be different, and so you need to cater to their needs. So it is client specific. Then you do the implementation, and implementation is when you're actually doing the work that you have selected in the plan. So you're debriding, you're educating, you're polishing, you're doing fluoride, whatever it is that you have planned out. When you implement it, when you implement the debridement, the education, the polishing, the fluoride, and whatever else you have planned for, that falls under this section, implementation. Evaluation, so the E stands for evaluation, and evaluation, as you can see from these arrows here, is ongoing. You evaluate after assessment, you evaluate after diagnosis, after planning, after implementation. It's not done at the end, it is done throughout. And the reason for this is when you're doing your assessment, so say you're doing your extraoral, intraoral assessment, at the end, you can evaluate and you can see whether you did the right, whether you did it correctly or whether you didn't. And maybe perhaps when you get to the planning section, you go back and into the assessment phase in the extraoral, intraoral chart, and you realize that you forgot something. So you're always going back to recheck, to reevaluate your findings in all sections. Lastly, this is kind of like a new one, is document. And it's not really new because we always should be documenting. So every time we do an assessment, we're documenting the findings. Every time we do a diagnosis, we're writing it down. Every time we do a care plan, we're writing it down, so on and so forth. So document is extremely, extremely important. So let's start with the assessment. And let's look at what exactly happens in an assessment, what exactly happens in a diagnosis, and so on and so forth. So we're going to start with the assessment. But here's a great visual that tells you exactly what happens in the assessment, exactly what happens in a diagnosis. So feel free to pause the video and look through these, but we will be going through it in detail in this video. Before I get into the assessment component, I have a question for you. The dental hygiene process of care provides a logical system for, I'll let you have a read and tell me what you think. So the answer is D. The dental hygiene process of care provides a logical system for determining the health and disease of a patient. So when you're assessing and diagnosing, you can figure out what the health and disease is of that patient, selecting appropriate interventions. So when you come up with a care plan, you're coming up with interventions. We're coming up with, treatment options that will be great or suitable for your client. And then measuring treatment outcomes. when you do a treatment, you always want to make sure it's measurable. So think about, when we're probing and we're calculating the bleeding index, when we're probing and we're calculating the cal, those are all measurable, because then when the client comes back at a later time and you redo their treatment, you have a baseline, you have their first measurements that you can use to compare to. So it has to be measurable. This is the best answer, because when you're looking at the process of care looks at ADPIE'd, looks at all of these. And so if you look at option A, for example, well, that's just the assessment phase, determining the health and disease of a patient. You can determine the disease in the diagnosis phase. So it doesn't include the remaining. So the planning, the implementation, the evaluation, that's not included here. B, selecting appropriate interventions. Well, that is only in the planning stage, because in the care plan, you're going to figure out what interventions, what things you'll do in their treatment. It doesn't address the assessment, doesn't address the evaluation or implementation, so that's not the best answer. C, measuring treatment outcomes and modifying the treatment plan accordingly. Again, this is when you're measuring treatment outcomes, that looks at the evaluation. So it's not where's the assessment, where's the diagnosis, where's the planning. That's not incorporated in that statement. But in this one, you're incorporating all of ADPIE'd. You're incorporating the assessment. You're incorporating the diagnosis. You're incorporating the planning. Okay, and then you're going to do the intervention, which is the implementation. And lastly, you're going to measure the treatment outcome to see if it worked, and that is your evaluation. So this one looks at all aspects of ADPIE'd. And remember, there's this also the D for documentation. So I know that's not addressed here, but this is our best answer. What about this question here? The comprehensive and systematic collection of data used to identify a patient's needs, oral health status, and general health and well-being defines assessment, diagnosis, planning, or implementation. If you said A, you are correct. The assessment is where you collect data, is where you gather all the information about what their patient's needs are. Once you gather the data, you'll be able to use that data to figure out what their needs are, whether they have good oral hygiene, poor oral hygiene, are they healthy or not healthy? So you're going to get all that information from the assessment phase. So when we do a health history or a personal dental and health history, the main reason we are doing that is to understand the patient's concerns. So one of the things we gather is not only just all the information about whether they're healthy, what conditions they have, and all that. It's also to figure out what their chief complaint is. We need to know what their chief complaint is so that we can address it. The number one reason they have come to you is to address their concerns, is to talk about their concerns, and they want you to address it. Another reason is we want to document baseline information. Baseline is an important word. Baseline is the first information you gather. The first information that they give you is known as your baseline. And then every time you see them after that, so if you see them 3 months after, or 6 months after, or 1 year after, that's all other information, but you always take that other information and you compare it to the baseline. When they update the medical dental history, when they update the health history, we're looking at our baseline and we're seeing if there's anything that can be updated, and we're going to add that into their file. So baseline is their initial information. So you're collecting their initial information, and then everything that gets collected afterward is not baseline information. This is your best opportunity to get the client to get comfortable with you. You're establishing patient rapport. You want that, nice two-way conversation happening between you and your client. And what's really important is, what if there are conditions that the client tell you where you need to make a referral, where you need to ask the doctor whether, we need to take pre-med, does the client need to take pre-med or not? And it's also a great legal document. We'll do another course on this, but the information should be stored securely, should be stored in a safe place, and all information should be made private or kept private. So when you look at the health history, which is the medical history, it's always changing, right? Because one day they could be healthy, one day they couldn't be, they're not healthy. So we need to update their medical history regularly. Each appointment, we are updating their health history, right? At the beginning of each appointment, it has to be updated. And as I was saying, this is your opportunity to connect. When you do the health history, it's your opportunity to connect with the client at that time. This is when they'll find out, or where you'll find out, the clinician will find out if they're smoking, if they have any stress, if they live in if they're in a poor living condition. Because when you get this information and when you get to your care plan section, you can now implement some strategies. So if they're smoking, you could do tobacco cessation if they're interested. If they have a lot of work stress and they can't cope, maybe you can recommend, refer them to a social worker or someone who can help them with manage their stress. If they live in a poor living condition, again, that might give you an idea as to why their oral health might be poor. Or, what can you do? If they live in a poor living condition, can you refer them somewhere? Are there dental centers that can help these individuals who don't have financial means to take care of their teeth? So all these information are being given to you during the health history component. When you do the health history questions with your client, make sure it's a private setting. Make sure no one else can hear, because sometimes the client have information to tell you, but they will not feel comfortable revealing it to you if it is not in a private environment. So be mindful of that when asking questions to your client. And use open-ended questions. So open-ended questions refer to questions like, instead of saying, do you have diabetes? Maybe you can say, well, what health concerns do you have? Do you see the difference? When you say, do you have diabetes, you say yes or no, which is okay, because in your health history form, you'll have like a place where they'll have to check off whether they have diabetes, HIV, and so on and so forth. But just be mindful as when you get those information, for example, when they check off what they have, make sure you elaborate on it, and you can ask questions like that encourage them to respond with words as opposed to yes or no. So for example, if you're doing a dental history, instead of saying, do you have anything bothering you in your mouth? Well, that's a yes or no question. They could say yes or they could say no. But what about if you ask something like, what is your chief complaint? Or what brings you to the office today? Do you see how that's not a yes or no answer? Do you see how the client has to elaborate now? So you want to use open-ended questions where you are not getting a yes or no answer, where you're getting an elaboration of an answer. So that's what you want to do when you're asking questions. Always use open-ended questions that require more than a simple yes or no. Now, when you are having that health history conversation with your client, you want to be eye level, okay? You want to be seated comfortably. The client should be seated comfortably too, and you should be at eye level. Don't have your client lie back. Your client should be upright at eye level with you. This is, again, a great opportunity to build on the relationship with you and your client, the therapeutic relationship where you're helping the client. So make sure that the client is comfortable and willing to give you the information that you need. And when you have that good therapeutic relationship, then that works great, because you are not only satisfied, but your client will also be satisfied. Now, your client will tell you some things that you might not want to hear. Like they might say they have HIV, or they might say they have AIDS or hepatitis or something. Remember, always take that information without judging them. Honest listening is important. Honest responses are important. There should be no bias, no judgment when they tell you the information. Now, when you do a health history, not only are you getting demographic information such as where they live, you're also getting their chief complaint, which is, what brings them in today. You're also going to ask them questions that pertain to dental history. So when was the last time you visited the dentist? When was the last time you had your teeth cleaned? How often do you brush? How often do you floss? That all comes in the dental history. In the medical history, this is a little more detailed, especially in school. It's very detailed, where we ask about what medications they're taking, what conditions they have, what allergies they have. All that is incorporated in the medical history. And then social history, you can ask them about, is English their first language? You could ask them nutritional questions. You could ask them about tobacco use. You could ask them about exercising, if they exercise regularly or not. All that could be incorporated into the cultural or social history and lifestyle history. So let's say you make an error. Okay, so you're writing things down in the medical history, and let's say it's a paper copy and you make an error. Remember, the health history form is a legal document. You cannot just remove anything and erase something. You can't do that. It has to be completed in pen, so in ink, so it cannot be erased. And if there are any errors, what you would do is you would cancel it out. So let's say I'm writing something on the medical history and I made an error. What I would do is I would cross it out like so, and then I would initial it. So I'd put my initial and I would date it. So today is, let's say, October 27, 2021. So I would date it. So that's what you need to do. You don't erase it. You don't I shouldn't be going like this and completely wiping it out. It's just one line where I put my initial and date. Now, one of the key things you're going to want to know from the health history is their antibiotic pre-medications, whether they need antibiotics. And one thing to keep in mind is the reason why we ask, or the reason why this is so important, is because when we are doing anything invasive, so if we're probing, if we're exploring, if we're debriding, what can happen is we can introduce bacteria into their bloodstream, and then the bacteria will go to other areas, like we see in this image. So it's really important for us to be mindful that if our client tells us that they have anything prosthetic, so anything man-made that was put into their heart, they probably will need pre-med. If they have a history of infective endocarditis, so infective is like infection, endo is heart, or lining of the heart, endocarditis is an inflammation in the lining of the heart. So if they tell you they have this condition, they need pre-med. If they have a congenital, so a disease that they were born with, congenital means you were born with, and it was not repaired properly, then they will likely need a pre-med. So be mindful of whether your client needs pre-med or not. Now, how often, let's say your client needs pre-med, what is the time span and that they have to take this antibiotic? Well, it is 1 hour before dental procedures, or even half hour. Darby says anywhere from half hour to 1 hour before you do the treatment. So it's extremely important. Some facilities, what they do, some dental office keep a supply of antibiotics, but as long as you give it half an hour to 1 hour before dental procedures, then you should be okay. Then the client should be okay. And then there are some treatments that, if they need pre-med, for example, so let me rephrase that. If they need pre-med, it is only for invasive treatment, so exploring, probing, anytime when you're going sub-G, anytime when you're going beneath the gum line, so probing, exploring, debridement. But when you're not going sub-G, like when you're doing radiographs, when you're doing fluoride treatment, when you are, doing ortho and you're not going sub-G, when there's bleeding on the lips or oral mucosa, they don't need pre-meds. It's only when you are introducing bacteria into their bloodstream, which is through probing, exploring, debridement. Always have the doctor's information present when you are asking about, if they have a doctor. If they don't have a doctor, recommend that they, see a doctor, because it's very important, especially if they have any conditions that, that is a red flag for you. You need to be able to contact the doctor. And the way for you to do that is you need a written request. So you want the client to sign off and say that, they are willing for you to contact the doctor. So you must obtain written informed consent from the patient before you consult with their doctor. Okay, so let's look at vital signs. So you've taken all the health history, and now what you need to do is you need to take their vital signs. And what are the vital signs we take? Well, we take temperature, we take pulse rate, we take respiration, and blood pressure. Now, when you're doing vital signs, and we'll go over them individually, you could do an inspection. Inspection means you just look at them. So, for example, when you do a respiratory rate, which is when you're watching their chest rise and fall, that is just inspection. That is just visual. You're just looking at it. Palpation is when you're doing a pulse and you're touching their radial, or the wrist, basically around the wrist, you're checking the radial pulse. That is palpation, when you touch. And auscultation is when you... Sorry, I said that wrong. Auscultation is when you are listening. So think about when you're doing a blood pressure. When you take a blood pressure, you'll have a stethoscope. You'll be wearing a stethoscope on your ears. So you'll be hearing for that heartbeat. So that's auscultation. So let's start with temperature. When you're doing a temperature reading, you want to be mindful of the range. So 96.8 to 100.4 degrees Fahrenheit is the normal range. It can vary. There's not one temperature that is normal for all people. And in Celsius, it's anywhere from 36 to 38 degrees. And of course, as we know, if you're, exercising, the time, if you're ovulating, if, your age, they all play a role with a temperature. So your temperature does change. But as long as they're within this range, we can treat them. Where can we take temperature? So many different areas where temperature can be taken. The one that we probably will use is the intraoral, using the mouth. Axilla refers to the armpit, so that's another method of taking temperature. People use the ear, people use the forehead, and people can also use rectal. So many different thermometers that are out there. As you guys know, this is more and more common, but we typically use the intraoral one. But any of these are okay, except for actually the mercury in glass thermometer is no longer standard of care and no longer recommended, so we don't want to do that. They say that the one that you scan across the forehead and the one that goes in the ear is the easiest and also most accurate. This one, sometimes if the client has eaten something cold or something hot, it can influence if you're doing something, or if they're smoking, for example, it makes everything's hot inside. So that can influence the readings there. Now, anytime someone has a high fever, we are going to reschedule them. The only exception is, let's say they're in a lot of dental pain. Then, of course, we'll treat them because perhaps the reason they're in pain is because, perhaps the reason they have a fever is because of that dental pain. But any elective dental treatment, so like debridement, for example, we would reschedule them if fever is suspected, because if there's a fever, there's probably an infection in their body. Pulse. So to take the pulse, you can actually take your thumb, side of the inner wrist, or on the thumb side is where you would put your two fingers. Do not put your thumb on this area because your thumb has a pulse of its own. So you must use the first two fingers and you put it near the thumb side of your client's wrist. And you feel for their pulse and you measure how many beats there are per minute. So having a stopwatch would be helpful. When you look at like the second hand, you can actually see, look at it for 1 minute and see how many beats you feel. If you have a difficult time here, you could do a carotid pulse as well. But again, the first two fingers is what we always use to feel for pulse. Tachycardia is they have above 100 beats per minute. Bradycardia is they have below 60 beats per minute. The normal range is 60 to 100 beats per per minute. That's what we want. That is normal, 60 to 100. So this is for an adult. So if you have clients who have 50, for example, or 105, then maybe wait 5 minutes and do it again and just be sure that it is in the normal range. So 60 to 100 is your normal range. Respiration. So respiration is how many times they're breathing. How many times is their chest rising and falling? So the best way to do this is you take their pulse and you pretend you're taking their pulse while you're assessing for this. Because when you are checking for respiration and you tell them, I'm just going to watch how many times your chest rise and fall, it's going to make them uncomfortable. They're probably going to be off with their respiration. So pretend you're doing your pulse, the pulse for the client, while you're checking for respiration. And the normal adult range is 12 to 20 respiration per minute. For children, it is 20 to 30. Children tend to have a higher respiration, a higher pulse, when we're checking for vital signs. Children's numbers tend to be higher for pulse and respiration. Adults are lower. And then again, just like with pulse, we have a high pulse like tachycardia and low pulse like bradycardia. The same thing we have for respiration. So the normal range is 12 to 20 respiration per minute, but if they have more than 20 respiration per minute, then it's tachypnea, which is rapid breathing. They're breathing really fast. And if they have, very slow, if they're breathing really slowly, then it's bradypnea. And sometimes if they're breathing really slowly, you might want to be concerned about the diabetic coma, that situation that they might be in. So if you see anything abnormal, refer them to their doctor. Let's look at blood pressure. So if someone has a high blood pressure, we call that hypertension. Hyper means high. And if someone has low blood pressure, we call that hypotension. Hypo means low. The only time we're concerned if someone has low blood pressure is if they go into shock, okay? So typically, the lower the blood pressure, the better. I mean, I shouldn't say the lower, the better. But you want to make sure they're in the normal range. And I will go over what the normal range is shortly. Now, the first number that you hear, so when you're wearing your stethoscope, the first number that you hear on the spigometer is the systolic number. This last number that you hear, okay, so you're listening to it on the stethoscope and you're looking at this, and the last number that you hear, the last beep that you hear, you catch that number, and that number is the diastolic. Okay, so systolic is the first number, or top number, sorry, and diastolic is the bottom number. Now, as we know, with blood pressure, there are so many factors that affect it, so many variables. And you can see, for example, let's see, I'm just trying to see something here. If you are, if you're a little overweight, the blood pressure might be a little higher. If your diet is not as good, the blood pressure might be a little higher. If you are taking birth control pill, we have to monitor blood pressure at every appointment. If you just came from an exercise session, your blood pressure might be higher. So there are many things that influence blood pressure. Darby says that when you document the blood pressure, you record the date that you did it and the arm. Was it the right arm or the left arm that you did it? Anytime someone has hypertension, high blood pressure, they're at risk for stroke. So it's really important that when we take their blood pressure, actually on a side point, we see our clients more regularly than they see a doctor. So we are more likely to catch something like hypertension because they come to us regularly, as opposed to going to a doctor. So it's really important that we take the blood pressure at their first initial appointment, and then if needed at subsequent appointments, because they could be at risk for cardiovascular disease and stroke. This is from CDHO, and you would follow your regulatory body as to what the recommendations are, but typically it's going to be very similar. So when you look at CDHO's advice for hypertension, they have two charts. They have one for without a history, so clients without any history of previous heart conditions, any no previous chest pains, no strokes in the past, no diabetes, no kidney issues, you would follow this chart. If they have a history, so if they've had past heart attacks in the past, if they have complained of chest pain in the past, if they've had stroke, if they have diabetes or any renal disease or kidney disease, then you follow this chart. And let's just assume you have a healthy client. Then anything under 130 and anything under 85, we are okay to proceed. But if they have a range, if you look at the systolic is between 130 to 139 and diastolic is 85 to 89, they're in the yellow zone. And the yellow zone means you would retake the BP after 5 minutes, typically on the opposite arm. And then if it's within that range, you can continue, but make sure you tell your client, you record all the readings, the BP readings, and you tell the client, you just follow up with their doctor. Now, sometimes you could have a reading of, let's say, 140 over 110. You take the higher number. So 110 is in the red zone for diastolic. So what you want to do is recheck the BP after 5 minutes and send them for a prompt referral to the doctor. You won't do any dental hygiene care, because anytime they're in the red zone, that's dangerous. So you don't want to treat them. You want them to be looked after by a doctor. Now, I just want to show you this one. When you have a client with a past history of these conditions, let's say you have a reading of 65 over 100, 165 over 100. Look what it says here. It says take the BP after 5 minutes and only perform non-invasive dental hygiene care. Non-invasive are things where you're not going sub-G. So you could take radiographs, you could do education, you could do extraoral, intraoral assessment, you could come up with a care plan, but do not go invasive, do not go below their gum line. So don't probe, don't explore, don't debride. Okay, let's look at extraoral, intraoral clinical assessment, which is a non-invasive type of assessment because you are not going sub-G. Now, when you do an extraoral, intraoral assessment, what you're looking for is a lesion. What you're looking for is anything atypical or anything abnormal. Many different ways you could do this. So when you do an extraoral, intraoral assessment, you'll be using many different types of skills. Observation, palpation. So observation is just looking at them. I'll give you an example. Palpation is touching. Auscultation is listening. And olfaction is smelling. So let's look at some examples. When they come to you from the waiting room and they're walking towards you, observe them. Really important. Do you notice anything abnormal? Do you think that, perhaps they have paralysis on one side of their body? Well, that's something you'll note when you observe them. And when you make your recommendations for oral hygiene recommendations, you might tweak it to help them. If they have arthritis, you might recommend an electric toothbrush versus a manual toothbrush, right? So observation is very important. Palpation is when you use your sense of touch. And one of the things we'll look at is there's many different types of palpations we can do. We could do manual palpation. You could do by digital. Or actually, I'll show you right now since I have you guys, since I have it close. By digital palpation, you could do manual palpation, and I'm going to go over what they mean in a bit. Okay, so many different types of palpation methods. Auscultation, this is when you're listening. So think about when you're doing the extraoral assessment or intraoral assessment and you're checking for the TMJ and you're checking to see if there's any clicking sound. That is auscultation because you're listening for any clicking. If they have slurred speech, perhaps it's because of their medications, or perhaps they're high, right? Maybe they just drank alcohol or something, and their speech is very slurred. And olfaction is smelling, and so if you smell alcohol breath, smoker's breath, a fruity acetone breath, that's linked with diabetes. So sometimes smell. Even though we wear masks, sometimes we can still smell it. They also give us some information. So here's a question. When performing the intraoral assessment, all of the following structures are assessed using palpation techniques along with visual inspection except one. Which is the exception? So if you said B, you are correct. The soft palate is just examined visually. Soft palate is further back, and when you go further back, and if you were to touch the soft palate, they're going to gag on you. It triggers the gag reflex. The tongue is okay, the floor of the mouth is okay, the hard palate is okay, but do not touch the soft palate. Just visually look at it because they will gag on you. So let's look at the different types of palpation techniques. So digital palpation is just you taking one digit or one finger. You're just using the index finger and you're moving it along the buccal mucosa. Or you could use along the floor of the mouth or the lingual border of the, or on the inside of the mandible, the lingual border of the mandible. So you're using one finger. But bidigital, bi being the key word here, is when you're using two fingers, a finger and a thumb. Okay, so when you're using a finger and a thumb and you're going all around and you're palpating the lips, the labial and buccal mucosa, even the tongue with two, with a finger and a thumb. So you're using two things. Manual palpation is when you're using the entire hand, all fingers on one hand, and you're using it to palpate perhaps the lymph nodes or even the thyroid gland. And bimanual, bi being the key word, is when you're using two things. So you're using the index finger on one hand and the fingers and the thumb of the other hand, and you're just palpating the floor of the mouth, the submandibular and sublingual glands, and even the lymph nodes. So bi means you're using two things. When you don't see the word bi in front of it, that means you're just using one finger or one hand. Bilateral palpation is when you're using a finger or you're using fingers, so many fingers, of both hands. So you're using two hands. Bilateral means you're using two hands and you're using it to palpate the lymph nodes to compare both sides at one time. Circular compression is when you're going in a circular fashion and you're moving the fingertips in a deliberate rotating fashion, and that, let's say you suspect a lesion and you want to palpate it to get more, to see what it really feels like, you might want to use a circular compression at that time. So when you do an extraoral clinical assessment, you are looking at all extraoral head regions. So the frontal region, the temporal, which is near the temple, the parietal, which is the side of the skull, the zygomatic, which is like your cheekbone, auricular, that's the ears, and occipital, that's the very back of your head, or the very back of your head. Okay, so make sure you're looking at all regions, including the buccal region, which is the cheek region. Mental is your chin. So be familiar with these terms and know that you are looking at each and everything. You're palpating and you are visually looking as well. You can get your client to tilt their head to the right or to the left, and you can feel the SCM if there's any lymph nodes around the sternocleidomastoid zone or muscle. And that is best palpated when your client turns to the right, so turns to one side and the other side. Another important thing to note is the best way to do an extraoral intraoral assessment, actually the best way to do an extraoral assessment is when the client is sitting up. I know sometimes we do it while the client is lying down, but it's easier and better for us to do it when the client is sitting up. I know when we do an extraoral assessment, we might think palpating, we have to palpate everything, but you also want to visually look, see if they're wearing hearing aids. When you're talking to them, do you notice any hearing issues? Do you notice that they're speaking extra loud? If they are, perhaps they have a hearing loss because they can't hear themselves. Check to see if their hand and arm are functioning, and just by looking at them, by observing, you can tell. Sometimes when you get them to sign, a consent form, you can tell whether they have compromised hand or arm function. When you do a head and neck evaluation, when you do an extraoral assessment, seat them upright. Really important. So don't have them lying down. Seat them upright when you do this. Lymph nodes are very important. What are lymph nodes? Lymph nodes are basically clusters along the lymphatic vessels, and what they do is they filter out toxic products. It's kind of like, you know, when you go to an airport and you go through a security checkpoint. So you might go to one security checkpoint, they'll filter out all the bad things, anything bad you have, they'll take it away from you. Then you go through another checkpoint, again, they filter out or take out all the bad stuff. So it's the same idea with lymph nodes. So you really want to palpate all the lymph nodes. Because if you find something, it might be, you might be concerned. There might be a reason to get concerned. It could be because they're sick. It could be, you know, because they have cancer. So there's many different reasons why someone could have inflamed lymph nodes, and it is important to get that looked at. If you see moles, if you see freckles, if you see scars in schools, we note all the atypical findings. And abnormal findings are something that's abnormal that you shouldn't see. So if you see needle marks on their body, if you see any trauma, any bruises on their face, you know, perhaps due to domestic violence, and those are things that, this is when you can ask them questions like, how long has this lesion been there? How are the lesions painful? You know, and you can even ask that for moles. Has the lesion changed in size? Is it painful? So there are many questions you should ask when you see something abnormal or atypical. Intraoral. So when we do an intraoral assessment, we are looking at everything inside. We're looking at the palate. We're looking at the pharynx, which is where the throat is, all the way, you know, at the back. We're looking at the tongue. With the tongue, always be sure to lift up the tongue and look on the underneath side, the ventral surface, and also the side, the lateral surface. Because if you see cancerous lesion, that's typically where you would find it. Here are some terminology we'll look at. So these folds of tissue, those are known as rugae, palatine rugae. This is your hard palate. You can palpate this. This is the soft palate. Do not palpate this because that will trigger the gag reflex. Your incisive papilla is here. Sometimes it can be irritated and inflamed. And this line that you see running along here, that is your median. Median means middle, palatine raphe. Your tongue needs to be palpated. It's a very important lesion site. Listen, if you see lesions, you're bound to see them on the tongue. Keep in mind that we have papillae on our tongue. So we have the circumvallate lingual papillae, which is right here, which is further back. We have filiform and fungiform as well. And if you look at the floor of the mouth, so you get them to raise their tongue, what we're looking at right here is the sublingual carbuncle. That's what that is called, sublingual carbuncle. Sometimes you can find a mandibular torus over here. This is your lingual frenum. That's right here. So sometimes someone can be tongue-tied if they can't lift up their tongue so high. Sometimes you can see those little flaps of, it's like strings sticking out, and those are not harmful. They're known as plicae fimbriae. And it's not harmful at all. Plicae fimbriae. Nothing to be concerned about. Differential diagnosis. Differential diagnosis is once you identify something, it could be something else too. So what else could it be? So you want to do a differential diagnosis so that you can identify. It's basically the identification of a condition by differentiating all the other pathologic processes that may produce similar lesions. So if you see a lesion, ask them how long it has been present, and ask them if the client have noticed any changes. If you see a macule, has there been any change in its size, any change in its appearance? We need to measure this. We measure the width, we measure the length, and we also, if it's something high, we also measure the height as well with the probe. Most common type of cancer you would see is basal cell carcinoma or squamous cell carcinoma. Melanoma is less common. Melanoma is just melanin. It comes from the word melanin, so pigment that you see on the skin. And it's less common, but if it is cancerous, it is quite fatal. So here's an example of an oral squamous cell carcinoma. Notice it's at the bottom, the ventral surface of the tongue. And these are the most common sites of cancer. You could see them in the lower lip, so really look at the lower lip. Look at the lateral border of the tongue, so really look on the side. Look at the floor of the mouth. Get the client to raise their tongue to the roof of the mouth so you can look on the floor of the mouth. And look at the soft palate as well. These are common sites where you can find this cancer. Really important that we do a thorough job with the intraoral screening or cancer screening process. What's really important is if you see a lesion, so this is a lesion I would be concerned about, but let's say there was a small lesion, so definitely a lesion I would refer out, but let's say there was a small lesion like right here. This is where you would ask them to come back in 2 weeks. And when you get them to come back in 2 weeks, you want to see if it has increased in size and if it's changed in color, it changed in shape over time. 2 weeks is when you want them to come back, because if it did not heal in 2 weeks, then that's a sign that it could be cancer. Of course, you're not going to tell them that I predicted cancer. No, that's the last thing you want to do, because you don't want to scare them at all. You would make a referral. You would refer them to their doctor or a specialist that can look after that lesion and then decide whether it is something to be concerned about or not concerned about. Teach your clients, use that opportunity in clinic if you have time, to teach your client how to do an oral cancer screening, how to look inside their mouth and find any abnormalities. Many different tools you can even find online to give to your client as to how they could do their own oral cancer screening. Because we all know early detection is key. If we can catch it first, we have a great chance of saving their lives. They have a better chance, better outcome. When you do oral cancer screening, there's many different types of oral cancer screening. So let's look at some of them. Let's say there was a condition, a lesion, and the dentist decided to do a biopsy. They could do a biopsy, is basically surgically removing that lesion and sending it to the lab to see if it's cancerous or not. And this is a punch biopsy where they use a tool, like it's called a tubular surgical instrument, that they use to get that lesion out and send it to the lab. You could do a swab. So exfoliative cytology is where they take a cotton swab, they rub it along, the lesion, and you send it to the lab. Transepithelial cytology is where they use a special brush like so, and they rub it along the lesion, and then they send it to the lab. So a swab is another way of figuring out whether the lesion is cancerous or not. A dye could also be done. So you place a dye, and if it turns a deep blue color, then that is a concern, and you can get that checked out. And then a light is called autofluorescence, and it's known as Velscope. You may have heard of Velscope, which is a brand name, where they shine a light and it detects. So here, do you see how it looks normal? But when you shine that Velscope light, you can actually tell that there is something wrong here. And so that is a sign that, they probably should get that looked at, because it could be cancerous. So it's really cool how we have technology available, such as Velscope, where we can identify lesions that are of concern. What they're saying now, American Dental Association, what they're saying is that they don't recommend using the swab or a salivary test or the Velscope or staining methods. They say that the best thing you should do is just do a referral. If the lesion has not resolved in 2 weeks, send them to a oral surgeon or send them to a specialist, and they can determine what the best method is. So try not to do this, is what they're saying. Just refer them out if the lesions don't heal within that 2-week time frame.